Thank you, chairpersons, respected teachers and colleagues. The next 20 minutes we'll discuss briefly about the management strategies for patients with type 2 diabetes and CKD. So most of the references are from this. One is the ADA 2026 guidelines, and second is the KDIGO guidelines 2022, and then British Clinical Diabetologist Association guidelines, and then JBDS guidelines. Most of these give comprehensive recommendation regarding how to use various drugs in diabetes and how to address CKD in diabetes. So we'll briefly see what is the role of kidneys in glucose metabolism and what is the effect of CKD in diabetes, and glucose homeostasis, how does it get affected in the patient with CKD, and how to manage diabetes in CKD and how to manage CKD in diabetes. As you all know, CKD is any patient who has more than 3 months of elevated albuminuria or low GFR less than 60. And in CKD and diabetes means the possible pathology is diabetes. We are not dealing with non-diabetic CKD. And usually it affects at least 1/3 of the patients, and around 10% may end up with end-stage kidney disease requiring renal replacement therapy. Not only the ESRD, the patients are at high risk for cardiovascular disease also. They have disproportionately elevated atherosclerotic cardiovascular disease, much higher than a diabetic patient without CKD. So all these patients must be on CVD protection also. So what is the role of kidneys in glucose metabolism? So in the glucogenesis, main contributor is the liver. 70% comes from the liver, but renal kidneys also contribute around 25% of gluconeogenesis to control the fasting glucose. And as you all know from the SGLT2s, 180 grams of glucose is filtered, and most of this are reabsorbed by SGLT2 in the proximal tubules. And in patients type 2 diabetes, everything is increased. Renal glucogenesis is increased, renal glucose absorption is increased. In fact, the increase in glucogenesis in type 2 diabetes is much higher from the kidney than from the liver. There are around 300% increase from the renal contribution when compared to liver in type 2 diabetes. And insulin, as you all know, is freely filtered in the kidney, and the actual renal clearance is much higher than GFR because there is a tubular secretion component also. And a non-diabetic patient, around 25% of insulin which is produced is excreted through metabolized to kidney. So majority excretion is done by the liver, around 25 to 30% is excreted by kidney. However, in a patient who is taking exogenous insulin, this becomes reversed. Because exogenous insulin, there is no first pass metabolism, so the main organ for metabolism of the insulin is kidney. So approximately you can remember 70% of endogenous insulin is metabolized from liver and 30% by kidney, whereas it reverses in exogenous. 30% is by liver and some majority is by kidney. So this is very important because in a CKD patient, when you give insulin, the chances of excessive insulin duration and hypoglycemia is high. So what are the effects of CKD in diabetes? We all know there is increased risk of hypoglycemia, but in early CKD there is also increased insulin resistance, and patient may require much higher insulin dose. There is impaired insulin secretion, decreased insulin clearance, impaired gluconeogenesis, and there are reliability issues with HbA1c. You need to modify your drugs according to GFR, and there are dialysis specific issues. So as I said, in the early CKD, especially type 2 and type 3A CKD stages, there can be profound insulin resistance, and patient may require much higher insulin doses or much higher medication doses. This happens due to various reasons like uremic toxins, hyperparathyroidism, vitamin D deficiency, etc. But this is very common. The insulin dose requirement comes down only in later stages. So as the CKD progresses, insulin resistance will persist, but the dominant factor here becomes the decreased insulin clearance and decreased gluconeogenesis. Thereby there is risk of insulin, as the CKD progresses, there is progressive decreased insulin clearance and also decreased gluconeogenesis, and both these contribute to excessive risk of hypoglycemia. So this sometimes patient may end up with no treatment at all. That's termed as burnt out diabetes. Everybody must have seen, in patient with CKD stage 5 or patient on dialysis, they may not need any treatment at all. You cannot say it is cured, but it is biological diabetes is there, but because of the progressive fall in GFR and excessive insulin persistence in the body, they may not require treatment at all. And HbA1c may not be reliable because of various reasons like anemia, shortened RBC lifespan, iron deficiency, erythropoietin therapy, carbamylation due to excessive urea and blood transfusions. So HbA1c can be used or not, it still can be used as long as the hemoglobin is, there is anemia is corrected and Hb is stable, you can still use, but it becomes more troublesome interpreting in patients on dialysis. So in this patient, you may have to go for alternative measures like CGM, etc. So how to manage diabetes in CKD? You need to choose the drugs not just for glucocentric effects, but also those drugs which can retard the CKD progression. And also you need to be careful about drug dosage when you have to calculate according to the GFR. You need to keep in mind the hypoglycemia risk and come down on the insulin or sulfonylurea doses accordingly. But you need not be over-aggressive in glycemic targets, especially in stage 4 or stage 5 CKD, because for getting the glycemic benefits, you may have to achieve good glycemic control for 2 to 10 years. So in the patient's shortened lifespan, shortened survival, you can relax the targets. So targets may be anywhere between 6.8 to 8 according to the patient's CKD levels, patient's other complications, hypoglycemia risk, etc. So it is an individualized target, not a single target. So all diabetes medications, by virtue of diabetes control, it can retard the CKD progression. But now we have drugs which have diabetes benefits, kidney benefits independent of glycemic control. So prime drug is SGLT inhibitors. So these drugs should be the first choice, any patient with diabetes and CKD. All three drugs, canagliflozin, DAPA and empagliflozin, have renal benefits independent of diabetes control. And we have some data for GLP-1 analog also. Subcutaneous semaglutide has been shown to have renal benefits. Other GLP-1 analogs also have, there is some supported data, but there is no primary renal studies. So in any patient with diabetes and CKD, apart from lifestyle, apart from metformin, the second line should be SGLT inhibitors. In addition, you can choose the GLP-1. Other drugs can be added for diabetes control, but they are not having specific renal benefit. They can, with regard to renal outcome, they are neutral. So there should be a SGLT inhibitor, and next line should be a GLP-1. Other drugs can be added. So how to adjust the dose of individual drugs according to the CKD level? Metformin can be used in full doses 2 grams per day till GFR 45. Between 30 to 45, you can decrease the dose by up to 50%. And less than 30, it is not indicated. So stage 4 and stage 5, it's not indicated. However, there is a lot of anxiety both among the patients and the treating doctors. When the GFR comes down a little bit around 40 or 45 itself, both the patients and doctors get worried and they may prematurely stop the drug. But one should remember, metformin is not nephrotoxic. It does not decrease the GFR. It is not causing any acute kidney injury. So this should be explained to the patient. The only reason we are stopping the medication in end-stage renal disease is because of the risk of lactic acidosis. And the risk is very, very low in up to stage 3 CKD. So you should not prematurely stop because there is survival benefit with metformin, and it should be first line in all patients which are indicated. So don't be too much worried when the GFR is fluctuating. Use it as long as possible, but you should inform the patient regarding sick day management. Whenever the patient gets dehydrated, vomiting, loose motion, the GFR, they can have acute kidney injury, and so in such situation, you should ask the patient to temporarily withhold the medication. Vomiting, diarrhea, they can temporarily stop because the GFR can come down from 40 to 30 during the dehydration. So the second line, SGLT inhibitors must be in the prescription, any patient with diabetes with CKD. All three drugs have been shown to have excellent renal outcome benefits, between 30 to 40% better renal outcomes, emparin, DAPA and canagliflozin. So this is a very clear-cut better renal outcome. There is no ambiguity. There is marked renal benefits between 30 to 40%. So this should be always be considered any patient with CKD. So that's why ADA now clearly recommends any patient with type 2 diabetes with CKD with GFR of 20 to 60 plus or minus albuminuria, SGLT2 must be initiated. It's not a maybe or can be, it must be initiated. It's a class 1 recommendation. And all three drugs have shown to be benefit. But the glucose lowering effect may be lower in patient GFR is less than 45, but they continue to have renal benefits and CV benefits. Once you start the patient on this medication, you can continue the patient on this medication till the patient requires dialysis or transplantation. So this is a strong recommendation. Previously used to adjust the dose of medication for individual drugs based on individual GFR. Now it's almost the same. Up to 20, there is no need to worry. You can still start the patient on all the drugs on maximum dose. GLP analogs also can be used in various stages of CKD, especially 3 drugs, that is liraglutide, semaglutide and dulaglutide, can be used in all CKD patients because the excretion is not renal dependent. So among this, we have semaglutide, subcu semaglutide. There is primary renal outcome trial is there, flow trial, that has shown that renal benefits with this drug. So after SGLT inhibitor, this is a recommendation to be used. Other GLP analogs, there is secondary outcome trials, but we don't have primary renal outcome trials. So one of the added benefit is that there is hypoglycemia risk is low. So in the place of insulin or sulfonylureas, these drugs can be considered in stage 4 or stage 5 CKD, especially when the patient is obese or requiring a lot of insulin. So 3 drugs, as I mentioned, liraglutide, semaglutide and dulaglutide, does not need any dose modification. The area says it can be continued even in patient on hemodialysis, but I don't use these drugs in stage 5 or ESRD because of various problems, but it can be considered. Sulfonylureas, the commonly used preferred drugs in CKD is glycoside and glycoside because the metabolism is by liver. Glimepiride, even though it is metabolized by the liver, some of the metabolites have hypoglycemic effect and they are excreted by the kidney. So hypoglycemia risk is higher in glimepiride. But in CKD patient, always don't be aggressive with sulfonylureas. Use submaximal dose, especially in GFR is less than 45, and avoid combining insulin. And it is not preferred in stage 4 and stage 5 CKD. This is one group of drugs which can be used in all stages of CKD, even in patient on dialysis. Linagliptin needs no dose modification. Other drugs can be used according to the stage of CKD. So DP4 inhibitors is CKD neutral, but it can be used in all stages. Pioglitazone technically can be used in all patients, even in hemodialysis patient, but the main problem will be the fluid overload, so you have to keep that in mind. Mostly it is not used in stage 5 or stage 5 CKD or hemodialysis patient because of the excessive risk of fluid overload, and also macular edema could be there. Aflagocin inhibitors, I mean, it is nowadays the ADA doesn't mention this drug at all. So it is a local action. It is supposed to not get absorbed by the gut, but miglitol has a lot of gut absorption, so it should not be used in CKD. So voglibose and agaribose, there are only minimal absorption, but whatever is absorbed, voglibose has less renal excretion. So if at all you are going to use, I think voglibose should be preferred, but again it's not recommended in stage 4 and stage 5 CKD. Insulin, as I said, the requirement will be biphasic. In the early stages, there can be insulin resistance, so the patient may require higher doses of insulin. But as the patient's GFR progressively comes down to stage 3B, 4 and 5, the insulin dosage should be reduced because of the loss of clearance of insulin and reduced gluconeogenesis. And also patient can have anorexia, weight loss, all these things can cause excessive risk of hypoglycemia. This is not based on any recommendation, just my recommendation. So just this can be changed for each patient. As the CKD progresses, we should try to come down the insulin dose prophylactically. If the patient is not under control, then we can go back to the previous doses. So stage 5 CKD, they may require less than 50% of the usual dose. So basal bolus will be the best regimen, but in stage 5 CKD, some patients may get control with only bolus insulin because the bolus insulin itself may act like a basal insulin because of the prolonged duration of action. Some patients may get managed only with basal insulin. So we can decide according to the individual patient. So what can be done for diabetes control in end-stage renal disease? Insulin is the preferred agent for all patients. Gliptins is one group of oral agents which can be used, especially when diabetes is not very high. You can try linagliptin. Other drugs which not commonly used, I also don't use it, can be tried like repaglinide, pioglitazone and GLP analogs. GLP analogs I've never used in stage 5 CKD or hemodialysis because of the problems, but it can be used. So what are the problems in hemodialysis patient? Here the primary problem will be the hypoglycemia risk on the day of dialysis. So they'll have different type of glucose control on dialysis days and non-dialysis days, causing high glycemic variability. During the dialysis days, there will be removal of uremic toxins, better control of acidosis. All this can cause improved insulin sensitivity. So on the day of dialysis, patient is at high risk for hypoglycemia. Especially in the 3rd hour of the dialysis, the maximum risk of hypoglycemia is there. And most of the risk is in the first 24 hours. So that is why you should always reduce the insulin dose on the dialysis days by at least 25%, both the basal and bolus insulin. If the patient is going to have hemodialysis on the lunch, reduce the lunch bolus insulin and also the night basal insulin by 25%. And some patients may get away with only thrice a day insulin, basal insulin on the non-dialysis days also. And if the pre-dialysis blood glucose is less than 130, better to advise the patient to take some carbohydrate to prevent further fall during dialysis, and always check blood glucose before dialysis and after dialysis. To the opposite of hemodialysis, dialysis, major problem will be the hyperglycemia, because for dialysis we need some osmotic agent for ultrafiltration, and the common osmotic agent used is the glucose. Other reagents can be used like icodextrin, amino acid, but commonly used osmotic agent is glucose at various concentrations like 1.5, 2.5 and 4.25. So up to generally the patient may require around 8 to 10 liters per day. So around 100 to 200 grams may be absorbed in a single patient. So this can cause significant hyperglycemia on the patient because of excessive glucose absorption. So generally the patients will need higher dose of insulin. How much here depends on the individual patient. The patient is on NPH insulin, you may have to shift the NPH dose to the morning if the patient is on CAPD. The patient is on automated protein dialysis, they will have a long night dwelling time, so we have to shift the basal dose to the night. And if the patient is using icodextrin, is a maltose derivative, it can cause falsely positive glucose values in some glucometers, so they may falsely diagnose hyperglycemia. So you should not use glucometers which use GDHPPQ if the patient is getting icodextrin. So this is about diabetes management CKD. So how to manage CKD in diabetes? Again, the aim should be not just diabetes control. You should try to prevent the retardation of diabetes. We should also address the excessive ASCVD risk. So it should be a comprehensive management, not just diabetes, hypertension, dyslipidemia, etc. So all these things you should address in an individual patient. So the first line treatment in any patient with diabetes CKD should be metformin, ACE inhibitor, ARB, SGLT2 inhibitors and statins. All these drugs should be there in a prescription in a diabetes patient with CKD. These are all first line class A evidence is there. And just one word, both ACE inhibitors or ARB plus and SGLT2 inhibitors both can cause temporary fall in GFR when you initiate the drug, when they initiate the drugs on any patient. So better to start one by one sequentially rather than starting both the drugs at the same time. Maybe you start ARB first and then after 1 or 2 months you can add on SGLT2 inhibitors. Otherwise there can be precipitous fall in the GFR. And subsequently add-on therapy you can use GLP-1 analogs, especially semaglutide if there is further proteinuria, or you can use finerenone as a non-steroidal melanocortin receptor antagonist. And antiplatelet in selective patients if they have multiple risk factors for ASCVD. So first 4 should be there in all patients, prescription should be there in all patients. These are additional therapies. Just few words regarding the ACE inhibitors ARB. Even though we know these drugs are working for so many years, many times the patient is who requires this medicine is either the patient is not getting the medicine or the dose is not used in the maximum level. Even though the evidence is very strong, even better than the SGLT2 inhibitors, many times you see the patient is not getting maximum dose of medicine. There is a gap between what is in evidence and what is practiced. Many times we complain there is lack of drugs, but what is available we are not using the maximum extent. Main fear is the fear of increase in renal creatinine, hyperkalemia worry, and also excitement about the new drugs, forgetting about the old drugs. So studies have shown that when the drugs is not used in the proper dosage, submaximal dose or if it is continued, the benefit is less. So the mortality is maximum only when the patient, the benefit is maximum only the dosage is maximum. So always initiate and try to achieve maximum tolerated dose, not just 20 milligram or something of telmisartan, always try to go to the maximum. Otherwise there is suboptimal beneficial is there. And don't worry about the increased creatinine in the initial time. There could be increase in creatine up to 30% in the first 1 or 2 months. That is how the drug works. In fact, the studies have shown that only those patients who have drop in GFR in the first 1 month, they have maximum benefit by this drug. That is how the drug works. It's a hemodynamic effect, nothing to worry about that. It should stabilize in the coming months. And also, many doctors, when they see hyperkalemia, they will abruptly stop this medication. These ACE inhibitors and ARBs have maximum benefit in diabetes and CKD. Don't just abruptly stop. Try to use maximum measures to continue the medication. So if the patient has hyperglycemia, review the other drugs. If the patient on NSAIDs, stop the NSAIDs. If the patient has spinal leptin, try to stop it. Try potassium restriction, add diuretic, correct metabolic acidosis. Try to reduce the dose and continue the medication. Or use potassium binders maybe once or twice a week. And also treating constipation also can be, because in CKD stage 4 and stage 5, colon excretes some amount of potassium. So all these things, try these measures before you stopping the medication. Because we get so much excited about SGLT inhibitors, we forget about the ACE and ARBs. And if the patient has continued proteinuria, you can add on this drug. So when this drug should be used? In type 2 diabetes patient with CKD and albuminuria, and albuminuria is persisting even on maximum dose of ACE or ARB, and GFR is more than 25 and there is no hyperkalemia. So dose is between 10 to 20 milligram based on GFR, and you have to monitor the potassium in the first month and then periodically. If there is hyperkalemia, you should stop the medication. So to summarize, all patients with diabetes and CKD should be on metformin, SGLT inhibitors, renin-angiotensin aldosterone blockers, and high insensitivity statins. Other drugs you can use like GLP analogs, antiplatelets, and phenytoin depending on the individual patient. But these all India should be there, must be SGLT inhibitors, RAS inhibitors, and statins. This I finished. Thank you for the patience.